we now move on to our last talk, which is our translational talk. So we're moving now a bit more into the clinical arena, and an area that's really transformed stroke has been sort of the increasing indications for reperfusion and thrombectomy, and a lot of this has depended on imaging. So Keith Muir, who's Professor of Neurology from Glasgow, is going to take us through the ischemic penumbra and tell us how imaging has really contributed to understanding this and taking it through to clinical trials. So welcome, Keith, and thanks for joining us.
Thank you very much indeed for the invitation. I'll see if we can successfully share and get the right screen available. So hopefully you'll be able to see that. So yes, I'll start by disclosing various bits of grant funding from various bodies, particularly Stroke Association, British Heart Foundation and others. And that's behind most of the work of ours that's contributing, although this is really a synthesis of work done by many other people over the years. So the ischemic penumbra remains remarkable currency in the stroke world, and its origins really lie back in the early 1980s, and this terminology really gained popularity following an editorial in Stroke from Astrup, Sesho and Simon, who were three of the main researchers investigating the effects of focal ischemia on different aspects of brain function. To quote directly from that paper, which synthesized quite a number of different research studies going back over the previous decade and a half, essentially it encapsulates the key concepts that we recognize still as the basis for the ischemic penumbra. So it defined two thresholds: a threshold of electrical failure, therefore loss of function in the brain, and this was largely based on EEG work in primate species, in baboons, when blood flow is reduced, so the brain ceases function at a particular threshold of blood flow. And a separate threshold, which is lower, which denotes failure of all bioenergetic processes. So that lower threshold is described on the basis of extracellular potassium concentration in those animal models. So the penumbra lies between one threshold and another: the threshold for tissue remaining viable and the threshold for tissue definitely being non-viable. And they defined the residual perfusion as being sufficient to maintain tissue ATP in focal ischemia, and they also defined the concept that this constitutes a circle, a ring around a densely ischemic center, which is termed the core, ischemic core, and the analogy with the progressive shadow around the edge of a solar eclipse. The penumbra is the terminology that has become our standard concept. So the concepts of different thresholds defining different elements of tissue failure need to be combined with time and also with space. So we've got a number of other studies, which includes this work here from Jones, which looked at severity of blood flow reduction and the likelihood of tissue progressing to infarction. And as we can see, that the more severe the reduction of blood flow, the more rapidly tissue progressed to a permanent state of infarction. And the time window in which one might potentially intervene in that study and in others was of the order of a few hours. Now, 3 hours at that time when these studies were undertaken seemed like a ridiculously short interval in which to treat patients, but of course has become standard of clinical care. It's also quite clear that there's a topographic significance, that this ring of penumbral tissue is encroached upon by the core as it expands over time, so that we have the spatial and temporal elements of the penumbra to consider. What sustains the penumbra? Well, that depends on leptomeningeal collateral flow. And that implies certain things. We can see in this laser Doppler flowmetry study from colleagues from Glasgow that after middle cerebral occlusion in this rodent model, we're looking top down onto the brain, you can see a hemisphere that's ischemic on the bottom half of the pictures. And after the first 30 minutes, you get a gradual restoration of blood flow consequent to collaterals kicking in, which is not an instantaneous process, but evolves over the course of the first 90 minutes or so following a middle cerebral artery occlusion. And the collateral flow that we see in humans, you can expect is coming from these leptomeningeal collateral vessels highlighted in the diagram, but also appreciate that this will have an effect of sustaining tissue in territories supplied by these leptomeningeal vessels. Now that varies from individual to individual, but does mean that consistently you have much more severe ischemia in a central area where the middle cerebral artery is essentially the end artery supply to lenticular striate perforators. Therefore the basal ganglia and insular cortex tend to be very severely ischemic very quickly, and that's reflected in all of the studies that we've undertaken subsequently and are now familiar with as the typical anatomy of cerebral ischemia. In terms of imaging, clearly, even from the initial editorial describing the Penumbra and onwards, the hope was that imaging would become a means of studying and understanding on an individual basis what was happening in terms of brain blood flow and brain function, and therefore the potential to therapeutically intervene. Going back to the original studies that have been done, the work of Jean-Claude Baron and colleagues looking at PET imaging, identified patterns within the triple oxygen labeled PET paradigm, which was allowing them to study both blood flow and metabolic rate for oxygen consumption. And they identified in a fairly small number of patients imaged approximately 11 hours after the onset of a stroke, that there were three distinct patterns which would form essentially the concept of the imaging signatures of the Penumbra. So whether there was a large volume of significantly reduced blood flow corresponding to a large volume of significantly reduced oxygen consumption, these patients all uniformly had a poor outcome. At the other end of the spectrum, there was a group of patients they studied where there was increased or normal perfusion and normal oxygen consumption, and in these patients, outcome was uniformly good. The group in the middle are the group that one would conceptualize as having a penumbra. The reduced perfusion is accompanied by a somewhat reduced but much more restricted reduction in oxygen consumption. So this is hypoperfused tissue that remains metabolically viable, and the PET signature would constitute a signature of the penumbra. Now, PET is not a very pragmatic technique for clinical use, so the subsequent imaging evolution has taken us through first MRI and then through CT. And in the early 1990s, after the use of diffusion-weighted MRI became studied in stroke, we were able to demonstrate features that would make diffusion-weighted imaging a fairly good candidate as imaging for the ischemic core. So in diffusion-weighted imaging, the normal gradient of sodium across the neuronal cell is not maintained as you get failure of sodium-potassium ATPase. Sodium enters the cell down the concentration gradient. The cell swells as a consequence of extracellular fluid entering the cell. So you get essentially a contraction of the extracellular fluid compartment, and that's picked up as diffusion-weighted signal change, which increases in volume anatomically over time after the onset of ischemia. And in this serial study from Stanford back in the late 90s, you can see the expansion over time of the diffusion-weighted lesion within the first 24-hour period, roughly speaking, and that corresponds by that stage to the final or follow-up infarct volume evident on flare or diffusion-weighted imaging days later. So that behaviour would very much fit in with what was conceptualised as the ischemic core progressing over time and eating into the penumbra. Coupled with a second technique with MRI, that of this dynamic susceptibility contrast imaging with gadolinium. Gadolinium contrast bolus passes through the brain tissue and you get a reduction in signal as a consequence. You can map out various parameters of brain perfusion. And what can be seen from these studies is that when you have a large volume of tissue that is hypoperfused, it is generally larger in the acute setting than the diffusion lesion. So correspondingly, this has become termed the diffusion-perfusion mismatch, the volume of tissue that is assumed to be the MRI signature of the penumbra. MRI has been supplemented in more recent years by CT perfusion. Using the same sort of contrast bolus techniques, you can pass contrast bolus through the brain. That will then allow processing of individual voxels within the brain to define perfusion by various parameters, including transit time, blood volume, and blood flow. And by coupling that information with thresholds that have been worked out from quite a number of different studies and refined progressively over time, it's possible to construct maps of tissue that is predicted to be penumbra and predicted to be ischemic core based on the delayed contrast arrival and the severity of blood flow reduction. Now, for CT perfusion techniques, we do not have a diffusion weighted equivalent in terms of a tissue signature of metabolic failure, but we do have the signature based on severe reduction of blood flow. And that allows us to construct these maps which will illustrate variation. So individuals who are clinically rather similar with middle cerebral territory ischemia may have, in one case, a very small volume of core but a very large penumbra, and in another case, the opposite, where the ischemic tissue is almost all core. And one would expect that the outcomes might be very different when trying to therapeutically intervene in these situations. So to summarize where we stand with imaging markers, there are a number of roughly synonymous markers that signify core and penumbra. So hypotenuation and non-contrast CT closely relates to diffusion lesion and MRI, which fairly closely relates to the severe hypoperfusion on any form of perfusion imaging. Whilst the penumbra is the tissue that has hypoperfusion, typically defined as delayed contrast arrival with various thresholds, but normal cerebral blood flow or normal DWI signal. The question then is reperfusion beneficial in the absence of a penumbra, in the absence of a mismatch? And defined on the basis of MRI, there are observational data that suggest that this may not be the case. That if one takes a group of patients in these two studies, those who have what came to be termed a target mismatch seem to derive benefit from reperfusion. Those who had what was termed by the diffuse investigators the malignant profile or an absence of mismatch seemed not to derive benefit from reperfusion. Similar was observed in the diffuse 2 observational study, again from colleagues in Stanford, where endovascular reperfusion undertaken quite late after onset of ischemia was undertaken. And again, selecting the patients with this small core but large penumbra, there seemed to be a significant shift towards more favorable ranking disability categories with reperfusion compared with no reperfusion, whilst among those patients who had no evidence of a mismatch, there seemed to be no very clear benefit and potentially somewhat harmful effects of reperfusion, although very small numbers, which again we've seen replicated in subsequent trials. To put all this together into the clinical trial setting, we have known that based on predominantly non-contrast CT selection alone, all of the clinical trials that randomize to thrombolytic drug treatment or control have a very strict time dependence. The numbers needed to treat increase very rapidly, and the benefit declines very steeply within the first hours, such that you lose any clear statistical benefit round about 4.5 to 5 hours from onset. It's also the case that that pertains to endovascular treatment. So if one looks at the Mr. Clean data from the Dutch trial that randomized patients on the basis of a CT and CTA appearance alone, we see more or less identical time-dependent benefit from reperfusion. So reperfusion rapidly loses its effect, and this effect disappears statistically by about 6 hours. Now, this is onset to time of reperfusion, not time of initiating treatment. So we have, on the basis of fairly simple imaging selection, fairly limited time to intervene to reperfuse. But in some individuals, we know that the time may be potentially longer. So this patient with moderately severe stroke, right middle cerebral occlusion, imaged within the first 8 hours, we have a small core and a large penumbra, which we would predict might benefit from reperfusion. Despite thrombolytic drug treatment at 24 hours follow-up, the patient is no better. The artery remains occluded, but the core remains small and the penumbra remains large. And that sort of observation raises the possibility that late intervention may be beneficial. In the diffuse 2 study, it was recognized that some people went from nothing to very large infarcts very quickly. There was an average behavior of evolution over several hours, and some individuals had a very long timescale for progression to infarction. We saw much the same from the Hermes dataset based around comparing trials that used very simple imaging and those that used perfusion imaging or similarly complex imaging, where, as opposed to the rapid decline in benefit from intervention, those who had more complex imaging selection paradigms that used penumbral imaging of some sort had a very flat profile, suggesting benefit much later. And that is what's been put into practice with the most recent batch of trials. So the DAWN and DFUSE-3 trials used paradigms where patients were selected on the basis of imaging for reperfusion up to 24 hours or up to 16 hours after last known to be well. Both trials showed a very significant benefit in terms of thrombectomy-based reperfusion, even at these late time points. DAWN selected really on the basis of ischemic core volumes defined in perfusion or on MRI diffusion imaging. DFUSE-3 selected specifically on the basis of a penumbral pattern. Penumbral volume had to be a minimum of 15 mils. The core volume was defined as being less than 70. And we're seeing similar with trials for intravenous thrombolysis. Wake Up, we used a somewhat different approach of using the diffusion signal change compared with the flare signal change to time the onset, but it may also represent a form of penumbral imaging, and showed benefit in patients of unknown onset from intravenous therapy within 4.5 hours of being woken or being found. And the EXTEND trial from Henry Ma and colleagues in Australia used specifically a perfusion mismatch hypothesis and showed that up to 9 hours after onset or at the midpoint of between going to sleep and waking, you gain benefit from intravenous thrombolytic drug therapies. Overall, taking all these data into account, you're getting significant shift towards more favorable outcomes. So the time windows are becoming much more flexible, much more blurred, both for mechanical thrombectomy and for thrombolytic drugs. And it's really all based around the concept of the penumbra that has its origins back in the early 80s and going back over a period of time before that to the study of cerebral blood flow and focal ischemia. So thank you very much for your attention, and I hope that's kept roughly within time.
It was a really great overview on it. It's come an awfully long way since those early studies.
And it's a lot easier than doing PET scans.
Yeah. But quite a big challenge implementing it in practice now, isn't it? And should we all be imaging up to 24 hours with CTP now in potentially intervention patients, or what would you recommend?
It depends what intervention's available to you. So if you have the benefit of a thrombectomy service that's available 24 hours a day, or even for part of the day, then you should be imaging. I think the evidence would certainly support doing that. There is a clear need to try and understand what proportion of patients might show these patterns and benefit from intervention. It's probably quite a small proportion in the 6 hour plus time window. If you don't have availability of these interventions, then intravenous thrombolysis remains possible with a slightly narrower time window. There are downsides to thrombolytic interventions where there was an increase in mortality as well as net benefit. Not clearly the case for mechanical thrombectomy, but I think perfusion imaging is something that should be mandatory for everybody with stroke. That view hasn't changed in many years, and the trials, I think, just back up the value of doing that from an individual patient treatment perspective.
And in patients who, where you've only got access to IV thrombolysis, what sort of time should you be, what would be your indication for out of hour, not out of window, out of 4.5 hours perfusion imaging? How far would you go? What patients would you do it in?
So EXTEND took people with known onset time up to 9 hours after onset, and it further took the group of unknown onset time, those who woke with symptoms, where the onset was between within 9 hours of the midpoint between going to sleep and waking up. So EXTEND has a sort of up to 9 hours, but then a potential additional several hours beyond that where there was benefit overall. So I think perfusion imaging definitely has a role in these patients of uncertain onset time and in those with late time window presentations. I think the more tricky question is, in fact, should we be using it automatically in people within time windows? And that's a question that haven't yet fully addressed from trial data.
Do you think we'll ever be able to answer that, or is it going to be too difficult now we're treating them all anyway?
It's very difficult to answer it unless you accept the idea of randomizing patients to not receive what people might regard as standard of care. And that's an uncomfortable situation for a trial to take that on. I think you have to persuade a lot of people to have equipoise in that situation, and that's very much more challenging. But I think it is quite clear that if you reperfuse very large ischemic cores early on, there is risk attached to that. So I think there is a justification for doing a trial in that setting.
Yeah, no, it's really. And we've had a question about neuroprotection. Do you think there's future for neuroprotection, either on its own or in combination in this patient group?
I'm going to have to say yes, but it's a thorny issue. We haven't solved neuroprotection in, 30 years of trying so far. But I think it's a question of trying to select the right patient group. A lot of the early trials suffered badly from throwing an intervention at a very diverse range of patients, many of whom we had no idea of what their physiological state was with respect to perfusion or metabolic function. And I think the future definitely has to lie in selecting the right patients for the treatment. But whether people have the tenacity to stay the course for neuroprotection and fully characterize it before leaping into big clinical trials is, I think, going to be the practical issue.
Just a last question from Michael O'Gara on CTP and lacuna stroke. Is it useful?
It can be. I mean, obviously the resolution of some of the perfusion processing is such that you can't reliably see lacunes in the acute setting, but you sometimes do, and they may be missed by the sort of automated processing that you get from software packages. We've certainly had plenty of examples from Rapid or Brainomics or other bits of software where the headline summary suggests there's nothing abnormal, but if you go looking at the perfusion maps, you can see a lesion. Whether that is useful in terms of treatment decisions is a different question. That's perhaps back to the should we use perfusion imaging to exclude patients from treatment within the first 4.5 or 6 hours. As a positive diagnostic confirmation, yes, it can be useful if you see it, but it's not reliable in terms of excluding stroke as a diagnosis. Okay, thank you. Well, thanks. That was a wonderful overview, Keith. And that brings our session to a close. And I'd like to thank all the 5 speakers. I think it just shows you how exciting stroke is at the moment, how much is going on and how much we're able to do in treating patients. And hopefully some of these new advances will lead to even more treatment approaches that we can offer our patients. But that's the end of our session now. So thanks for joining us, and goodbye.